Welcome and thank you for joining our roundtable discussion on the latest advancement in pancreatic cancer. I am Maen Abdelrahim, Chief of Gastrointestinal Medical Oncology at the Houston Methodist Research Institute and Neal Cancer Center. With me today, 4 of my esteemed colleagues who are committed to delivering unparalleled care for pancreatic cancer. And we're going to start with the introduction. Dr. Ashish Saharia.
Hi, I'm Ashish Saharia. I'm a liver transplant and hepatobiliary surgeon at Houston Methodist Hospital.
Dr. Schwartz.
I'm Dr. Mary Schwartz. I'm the Deputy Chair of Pathology here at Houston Methodist. I practice predominantly surgical pathology and cytopathology with a focus on GI pathology, including pancreatic biliary cytology.
Dr. Esnaola.
I'm Nestor Esnaola. I'm the Chief of Surgical Oncology, Interim Director and Deputy Director of the Houston Methodist Neal Cancer Center, and I focus on hepatopancreatic biliary malignancies.
Dr. Dacha.
I'm Dr. Sunil Dacha. I'm the Director of Advanced Endoscopy at Houston Methodist Hospital, and my predominant practice is pancreatic biliary endoscopy, in addition to colorectal polyp removal.
By 2030, pancreatic cancer will be the second most deadliest cancer for GI cancer and in general for all cancers. It's called the silent killer because by the time the patient presents to the primary care physician with symptoms, it's already late and it's advanced stage disease. And actually has been shown that 2/3 of the patient will present with advanced disease with poor prognosis. So by the fact that the patient present with advanced stage, early diagnosis of pancreatic cancer might provide a better outcome. And the challenge of diagnosis early pancreatic cancer and along with the high mortality rate, it's important and essential to understand the most common factors for risk of pancreatic cancer or the factor that might make certain patients at higher risk than others. So it's important to understand those risk factors and we can, at that moment, intervene and have some prevention. So, Dr. Dacha, what is the most common risk factor for pancreatic cancer? And as advanced gastroenterologist, what's your approach to diagnose these precancerous lesions?
Right. Unfortunately, like you mentioned, pancreatic cancer is one of those lethal diseases where incidence is pretty much equivalent to prevalence, which speaks to the lethality of the disease. When we're talking about risk factors, the traditional risk factors like any other cancer, smoking has been shown to be a very high risk factor for pancreatic cancer. Obesity, someone having chronic pancreatitis does predispose them to a very high risk for pancreatic cancer. Having a pancreatic cyst does predispose to pancreatic cancer, so that's the reason why you survey them and intervene on these when required. And in addition to these, there is 2 various different categories of genetic syndromes for pancreatic cancer. One is familial pancreatic cancer, where you have a pair of family members with pancreatic cancer that will predispose you for a high risk for pancreatic cancer, and that warrants pancreatic cancer screening. And the other is inherited genetic cancer syndromes, which will also increase your risk for pancreatic cancer. And of these, say for example, Peutz-Jeghers or having a familial atypical melanoma mole multiple myeloma syndrome, having those syndromes by itself will qualify you for pancreatic cancer screening. In addition to these, there is various other cancer syndromes, like if you look at the breast cancer syndromes, BRCA1 and BRCA2, that does increase the risk for pancreatic cancer. However, you qualify for screening only if you have a affected family member with pancreatic cancer. In addition, you have the adenomatous polyposis coli gene mutation, then you have ATM mutation, PALP2 mutation, and all these will qualify you for pancreatic cancer screening only if you have an affected family member with pancreatic cancer. And in addition, another caveat is earlier studies have shown that having diabetes is a risk factor, but what we've known over the years is that patients have diabetes predating to their pancreatic cancer, suggesting that there is an altered glucose metabolism, suggesting that if you develop a de novo diabetes or someone with a very well controlled glucose control suddenly loses the control, that should raise a red flag for screening for pancreatic cancer.
And how is your advanced gastroenterology to screen for those patients, ARCB? What's your approach for those patients?
Right. So first and foremost important thing is identifying the right patient population. Like we were talking about earlier, the high risk factor population is one of those with the cancer syndromes that we talked about. So once they qualify for it, we go based off what is called as CAPS guidelines, which is an international consensus statement, where what we do is in someone who qualifies for pancreatic cancer screening, we offer them an annual endoscopic ultrasound, MRI of the abdomen, CA19-9, which is a tumor marker, HbA1c, which is again a marker for diabetes. Put everything together in a multidisciplinary fashion does help us identify some patients with early pancreatic cancers. In addition to it, at Methodist, we are actually starting a pancreatic cyst clinic being headed by Dr. Saharia. So in a multidisciplinary fashion, when we identify pancreatic cysts, we go by established guidelines to see which of the cysts are high risk for cancer transformation, and then we intervene on these by endoscopic ultrasound, and then we aspirate fluid from this and send it out for molecular mutation analysis in addition to some fluid markers like CEA, amylase, and glucose, which will tell us the risk of these transforming into cancers. And then we discuss in a multidisciplinary fashion in our tumor boards to decide what should be the next approach for these patients. Do we survey them, or is it ideal for them to have a surgical resection based on their risk profile? And in addition to this, not just by EUS, sometimes you have patients coming with recurrent acute pancreatitis and there is a dilated pancreatic duct. And in these cases, sometimes we do what we call as a pancreatoscopy, where there is a special camera that goes into the pancreatic duct to identify any signs that it is a main duct IPMN that predisposes to pancreatic cancer. So there is a lot of advances that have happened in advanced endoscopy with which we are able to risk stratify patients, one, that are at risk, two, that will have a high risk for transformation to cancer. And this is where the role of multidisciplinary teams comes in, where like our surgical oncology team and Dr. Saharia's team come in place to take care of our patients before they get a cancer.
And that's very helpful, and hopefully by early intervention, advanced gastroenterology, we're able to identify these precancerous lesion or catch cancer at early stage, where the outcome is much better than somebody with an advanced stage disease. We generally, when we talk about pancreatic cancer, we refer to the most common type of cancer, which is ductal adenocarcinoma. However, there are multiple types of pancreatic cancer. And Dr. Schwartz, can you tell us about the type of pancreatic cancer? And when we biopsy a pancreatic mass, for example, and send you the tissue to your department, how you differentiate between these type of cancer? And when the sample or like the curative resection is done by our surgeon, Dr. Saharia and Dr. Esnaola, and they send you the samples, what pathological feature that you see on this sample that said, hi, this is a high aggressive cancer and the likelihood of recurrence is really high?
Okay. I would just segue back to Dr. Dacha's discussion about pancreatic cyst analysis, and I would just add that many of them are paucicellular, but cytology does play a role in picking out the high-grade atypia, and we've been involved in some of those studies. This is people at Mass General and elsewhere, and so cytology can add additional information as far as which patients do need surgery or which patients you can watch. To go back to your question, Dr. Abdelrahim, pancreatic ductal adenocarcinoma is certainly the most common type of pancreatic cancer. Probably 95% of pancreatic cancers are ductal adenocarcinoma. There are uncommon variants, some of which have a little bit better behavior, colloid carcinoma, medullary carcinoma, some of which have a worse behavior, adenosquamous carcinoma. But honestly, at the current time, and again, things may change in the future, the treatment is the same. So depending on the sample, a pathologist may or may not be able to pick up some of these unusual variants. Probably the most important thing on biopsies is, and these biopsies may be small core biopsies such as shark core biopsies, or they may be fine needle aspiration. Probably the most important thing is to actually be able to make the diagnosis of pancreatic cancer. And this is very challenging for pathologists across the world. As you well know, most of the pancreatic tumors are stroma, so there's often not many cells to be had, and many pathologists are uncomfortable with that. The big differential would be to not overcall chronic pancreatitis as cancer, which we have seen elsewhere. And the usual dilemma is, though, just the inability to recognize pancreatic cancer. So we at Methodist and others have been very active in education locally, regionally, nationally, and internationally, because as you said, this is a growing, exponentially growing cancer and affects people worldwide. As far as making what we do in a curative resection to look for the chance of recurrence, the most important thing is to work with people like Dr. Esnaola and Dr. Saharia of actually looking at the resection and looking at the margins, looking at important landmarks. Microscopically, the things that we're looking for are the surgical margins free? Is there lymph node involvement? Is there perineural invasion? Is there lymph node invasion? Molecular workups are very important, as you know, for patients with locally advanced and metastatic disease. At the current time, they're really not part of the workup of a curative resection. So really a very complete resection. Going back to the biopsy, you had asked me about what we do. I think the most important thing that we can do is, one, to educate people on the diagnosis, but two, given the fact that molecular testing does play an important role in those with, and unfortunately, as you said, most of these patients, when they present, have either locally advanced or metastatic disease. The most important thing, and the thing that we teach, is to try to preserve as much tissue as possible, to not use it all up for diagnosis so that molecular testing can be done.
That's very helpful. It's important always before we start treatment is to know the right diagnosis of the cancer. So based on that, we can choose the right treatment, because these different type of pancreatic cancer have a different approach. And as you highlighted also, these features of after curative resection of the cancer, sometimes it helps us as GI medical oncologists to decide about the adjuvant therapy. How much adjuvant should we be like adding radiation to the adjuvant or not? So this feature that we read in your report is very helpful to guide us what next. And pancreatic cancer in general, when we stage pancreatic cancer, we don't follow the TNM staging system that is for solid tumor in general, because we found that is pancreatic cancer, the clinical staging is actually more relevant and more important to decide should we go for a curative intent or should we go for the palliative intent on these cases. So Dr. Esnaola, what are the clinical stages for pancreatic cancer, and what's your advanced surgical approach to treat those that can be treated by a curative intent, the early stage pancreatic cancer? Can you comment about that?
Sure. So, I mean, and I agree with you. I mean, I think AJCC staging is not as helpful for us as the clinical staging that we currently use. And we normally think about patients as having either metastatic or non-metastatic disease. If it's non-metastatic, we then break them up into various categories of localized, which is technically resectable, what we call borderline resectable, which are tumors that are a little bit larger, abutting the adjacent vasculature, whether it's the veins or the arteries. Sometimes patients with very elevated tumor markers, such as serum CA19-9. And then we look at patients that have unresectable local advanced disease. Those are patients that we may be able to downstage and take to surgery, but oftentimes that likelihood is certainly lower than for borderline resectable cases. Mary brings up a good point, which is that, we're lucky to work in a system that's as robust and large as ours, that also has a tremendous expertise in the management of these individuals. We have a very deep breadth of expertise across multiple disciplines. So when these patients come to us, we always bring them to our multidisciplinary tumor boards. We've got multiple tumor boards across the system. We have a very large one here that many of us participate in, as you know. And that's an opportunity for us to look at all the information on that individual, their imaging. We oftentimes will almost always review their outside imaging. Imaging from within is very carefully looked at by a pathologist, oftentimes second or third time when it comes to that tumor board. And that's when we sort of really tease out exactly what that patient has. It's interesting because oftentimes we'll see patients that are sent to us with what are thought to be pancreatic cancers, and actually they're benign lesions. It could be a serous cystadenoma that on further endoscopic imaging actually ended up being a benign cyst. We have patients that were billed as having pancreatic cancers that actually were other tumors, such as solid pseudopapillary tumors. So that discussion is really crucial. If it is indeed a pancreatic adenocarcinoma or neuroendocrine tumor, as Dr. Schwartz mentioned, that's when we start to sort of figure out how we're going to manage that individual. Talking about adenocarcinoma, again, those categories are really crucial: localized, borderline resectable, and unresectable locally advanced. The folks in the first three categories potentially can get neoadjuvant therapy. I think it's controversial as to whether or not patients with localized should get neoadjuvant. I would say more and more we recommend that because, as you mentioned, we think many of these individuals may have occult metastatic disease, so we think that there's benefit in giving them neoadjuvant therapy. But clearly there's no level 1 evidence that should be done in that setting. I would say for borderline resectable, those are patients that certainly should not go to surgery up front. I would say both ourselves and Dr. Saharia and his colleagues give those folks neoadjuvant therapy. Usually systemic plus minus chemoradiation if we have residual concerns about margins. The unresectable locally advanced, we always obviously recommend upfront systemic, sometimes with adjuvant chemo-RT. We have had some of those patients, as you know, downstage and go on to surgery. So I think that multidisciplinary evaluation up front, a very aggressive approach to managing these individuals is really crucial. The other thing that I think is important too is really sort of looking under the hood to make sure you're not missing metastatic disease and that you stage these patients optimally. So oftentimes we'll do diagnostic laparoscopies on many of these individuals at presentation to make sure they don't have occult peritoneal disease that might be missed on CTs or PET scans. So again, I think we take a very comprehensive, very multidisciplinary approach to these individuals to make sure we know exactly what we're dealing with and what the next steps are going to be. And I think that has really benefited the care of these individuals.
And that's very helpful because when we have patient diagnosed with pancreatic mass and we have the tissue diagnosis and Dr. Schwartz look at it and confirm, yes, it is pancreatic adenocarcinoma, and we start talking, the next step is let's try to maximize the curative intent, and that way we send it to a multidisciplinary tumor board. We discuss, can we cure this cancer? Can we resect it? Where Dr. Esnaola and Dr. Saharia and the team can help us to do that. But some cases, which is like the 2/3 of the cases in pancreatic cancer, patients come with advanced disease. And those advanced diseases, they end up in our clinic and the GI oncology and our cancer centers. And we have multiple clinical trials going on for pancreatic cancer, but sometimes a patient is not always eligible, and we go back to the systemic treatment. For pancreatic cancer, it's been a challenge for systemic treatment. And since 1996, there was one drug, gemcitabine, and it was not too much successful been for almost 15 years till 2011, when FOLFIRINOX was FDA approved to treat palliative pancreatic cancer. And that added life to the patient, median overall survival 11 months. And 2 years later, 2013, Abraxane got FDA approval, and the median overall survival is 8 months. Unfortunately, immunotherapy didn't make it for pancreatic cancer, and because of this trauma. The trauma of pancreatic cancer is really immunosuppressant, and it is acidic. And as Dr. Esnaola mentioned, the trauma can be 80% of the cancer. So nowadays, there's a hope to treat pancreatic cancer beyond the systemic chemotherapy. We live in the era of precision oncology, and basically the same cancer in two different patients might not be treated the same way. And targeted therapy start to make its way to pancreatic cancer. KRAS been mutated on pancreatic cancer for almost 95% of the cases, and we never thought that this is going to be a target till the last few years when we found that KRAS G12C is an actionable mutation. That small molecule can be used to shut down this pathway, and multiple drug now has been designed and used in clinical trial and FDA approved. And RG1 is another example, HER2. So even though this mutation or alteration is a small percentage in pancreatic cancer, yet for that patient who have that mutation, it makes a lot of difference. So we at Houston Methodist, in collaboration with our Department of Pathology, with Dr. Mary Schwartz and her team, we do a lot of molecular profiling. When we have our hand on a piece of tissue, the next step is NGS, next generation sequencing, hoping to find a mutation that we can target and add more life and quality of life for those patients. So this is as far as adenocarcinoma or ductal adenocarcinoma. However, as Dr. Schwartz mentioned, there is different type of pancreatic cancer, and neuroendocrine tumor of the pancreas is a unique subtype or unique type of pancreatic cancer. And sometimes it's come with carcinoid syndrome symptoms, like flushing, palpitation, abdominal pain, and diarrhea. So those have a different approach for treatment. So Dr. Saharia, what's your approach or surgical approach for those patients? And I know you practice on Houston Methodist Transplant Center, which is ranked highly, it's the second in the country. Do you offer those patients transplant if they have liver-only metastasis from pancreatic neuroendocrine tumor?
Well, definitely we can offer liver transplant for patients who have metastatic disease. But I would like to first mention that one, neuroendocrine tumor is not as aggressive of a tumor as pancreatic adenocarcinoma, and not all neuroendocrine tumors need to be resected even when you see them. You can actually follow them for a long time without having to do surgery. And some people are older, you can just sit and watch on them, and you don't necessarily need to take out. And there is some size also, which is variable depending on age of the person. But as far as doing liver transplants for neuroendocrine tumors, I have to say up front that it is a rare event when you actually do land up transplanting somebody for metastatic neuroendocrine tumor. But we have restrictions also, because liver transplant can help those people who have metastatic disease, especially if they have carcinoid syndromes. But we have to remember it's a cancer that likes to spread. So even after liver transplant, these tumors can actually come back in the transplanted liver. So we have to be careful when we transplant people who have neuroendocrine tumors who have metastasized. So we can only transplant tumors that are lower grade. So in grading system, we have the G1, G2 is the lower grade tumors. And when we talk about mitotic index, and we talk about Ki67, which basically tells how aggressive our tumors are. And if they're of a lower grade, usually we say that a Ki67 of less than 20, mitotic index of less than 20 per 10 high power field is what we usually go by. That falls into the G1, G2 category. And of course, the liver doesn't have to be full of disease. So if only one part of the liver has tumor, then you can resect it. You don't need to transplant them. So you have to have liver with metastatic deposits on both sides, or in such a way that you cannot resect it. It's present at the dome, or present, or there's a big tumor burden at the hilum. Then yes, they fall under the category of liver transplants. Again, patients shouldn't be too old. They shouldn't. And UNOS guideline says 60 years of age, but we know that age is just a number. UNOS gives us guidelines, but every patient gets discussed in the National Review Committee, which basically goes over every patient that we list, and then we transplant people if they're well-controlled tumors, if they're not high-grade tumors, lower Ki67 mitotic index, and we can transplant them, and then help them with not only metastatic disease, but if they're having any carcinoid syndromes that go with it.
So it sounds like it is for
It's
selected
it's
patients.
there for selected patients. It's not something that we offer very frequently. We'll see. I mean, there are other approaches to managing patients who have metastatic neuroendocrine tumors to the liver, and we have to actually have at least a 6 month to a year gap between the diagnosis of tumor to transplanting, because we don't want to go too early into somebody whose tumor is likely to metastasize to other organs and outside of the liver. And also, before we transplant, we want to make sure that we have addressed the primary tumor. If it arose in the pancreas or wherever it arose from the gut, we need to address that before we go and transplant somebody.
Yeah, as a GI oncologist, I always look for opportunity when there's a cure can be done, and the cure we know that can be done by surgery. And Esnaola, Dr. Saharia, and the team, and a transplant. Since we are high volume center with good quality, a good outcome, so that we sometimes we see unresectable neuroendocrine tumor that fit the criteria that you mentioned, Dr. Saharia. We hope that is to bring it to your tumor board for discussion, and this is the fit, or get your feedback on those cases. That's always the hope, and we try not to keep the patient on treatment for lifelong. If it is resectable or transplantable, we aim for that. And since we have the resources that we are under the same umbrella of a Houston Methodist multi-center and multi-approach, we take advantage of that, and with collaboration with our teams. And we follow a holistic approach to treat our patient with pancreatic cancer. As we know, it is a deadly cancer, and it affects the patient and affects their family. And the holistic approach, we try to provide resources for the patient, for the family, nutrition consult, musical therapy, all this approach. So any comment from my colleague about your holistic approach for your patient, when you see what you add, how you approach those patients and their family and loved one?
My standpoint, I think I worry a lot about the family members who are actually supporting those who have pancreatic cancer, because everybody knows that pancreatic cancer is just a deadly disease. It's, no matter, we've made advances in other cancers, and I'm hoping that we make enough advances in pancreatic cancer that we're able to fight this disease. But the family actually suffers a lot, because here you have somebody Sometimes we're treating people who are like very young, in 40s, and they have young kids, and so the family support is what I think does a lot. And we have counselors for patients and patient families who are going through this process of pancreatic cancer and their diagnosis and full treatment, which might take up to a year. So it's a big thing for the family.
Indeed, it's been a high burden on the patient and their family, and we know that we hope by collaboration, by clinical research, by clinical trials, and by the science, the translational research we do from our research institute that we bring to phase 1 to clinical trials, we hope to bring more new drugs, more hope, and this can be done only in collaborative effort. I would like to thank you so much for your time, for your expert opinion today, and for all what you do to help our patient in their journey for fighting pancreatic cancer and fighting cancer in general. And we appreciate your time today. Thank you.
Thank you.